The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. Earlier today, I was listening to an episode of the New Yorker podcast. It was an interview with David Remnick and Jon Stewart, and they were talking in part about how it's incumbent on anybody with a platform right now, which is everybody, right, because we all have social media, to get out there and say something and help fight back and combat misinformation, that sort of thing. So maybe until further notice, I will do a little segment in the beginning of each episode about something related to what's going on in medicine right now and try to put out correct, scientifically sound, evidence-based information for anybody who might be looking for it or hearing otherwise from other sources. So what do we have this week? The government shutdown continues. According to USA Today, on November 5th, if the shutdown is still in effect, it will be the longest shutdown in U.S. history. The Democrats are asking the Republicans to extend the Affordable Care Act subsidies for marketplace insurance plans, which are set to expire. If that's allowed to happen, people's insurance premiums are going to go up significantly. Obviously, there are a lot of other issues that the Democrats are concerned about, and probably this is not the main reason that they decided to make this shutdown happen, but that's the issue that they're asking Republicans to address in exchange for them voting on a CR to reopen the government. The Republican-controlled House of Representatives currently out of session. They're not even in Washington, so it's not looking like we're working too hard on making a deal. And it always sucks that normal people are the people who are impacted by this stuff. Where I live, Huntsville, Alabama, is built entirely on the defense industry, so the government being shut down is affecting a lot of people I know, a lot of patients. The town is starting to feel even a little less crowded because people are not going out. They keep running stories in the newspapers about how the restaurants are suffering because of all this. We keep seeing stories about how food banks are in desperate need of donations, money, food to help feed people who are affected by the shutdown. So that's where we are with that. Recently, the Texas Attorney General announced that the state of Texas is suing the manufacturer of Tylenol for allegedly ignoring evidence that Tylenol is harmful during pregnancy and causes autism. The American College of Obstetrics and Gynecology, ACOG, as well as the American Academy of Pediatrics, both very clear on their position on acetaminophen use during pregnancy, safe, never been shown to be associated with autism. I'll put links to the text of the lawsuit itself, which is like 50 pages long if you're interested, as well as statements from ACOG and AAP in the show notes. And one final bit of misinformation to correct. Today I learned that a healthcare professional told my parents that they should wait to get their flu shots because the quote-unquote second batch of flu shots that comes out in the middle of flu season is specifically tailored to the strains that are circulating right now. That is 100% incorrect. I'll post a statement from the FDA talking about how the process worked this year and which strains were covered. They have a meeting in February to figure out what strains they're going to protect against for the next set of flu vaccines. So when flu vaccines become available, those are the ones that are covered for this flu season. They do not change in the middle of flu season. Please go get your flu shot if you have not already. And there's no reason to get a second flu shot or to wait for some later dose of flu shot to come out during flu season. That is not correct. All right, on to the next topic in our Alphabet Soup series. This week I'm going to talk about insomnia. This is such a prevalent problem. So many people complain about sleep issues. I feel like this is a problem that tends to get worse over time. I've always learned that sleep patterns change over time, but now in seeing elderly patients all day long, I can confirm that it is a big problem for elderly folks. One thing I see frequently that would not necessarily be classified as insomnia, I don't think, but when people retire and don't have anything to do, a lot of times they end up staying up later during the night and then sleeping later during the day, and eventually they essentially flip their circadian rhythms around, and so their families will complain that they're tired during the day and take naps and stuff. If you dig into it, a lot of times you'll find that that's just because they're sitting up all night. And I don't know that I really see that as a problem. You know, if they're getting enough sleep altogether, hey, work the night shift. If I was left to my own devices, that's exactly what I would do. I'd stay up till midnight, 2 in the morning, and then sleep until 10. I think some people are just wired to feel better that way. So I don't get too worked up about that kind of thing. But a lot of people have trouble falling asleep, have trouble staying asleep, and a lot of people want to take sleep aids. I would think everyone who works in medicine anywhere would know at some point what it feels like to have to work in the middle of the night or to work an extremely long shift or to come to work without enough sleep. I can run on 3-4 hours for like a day or two if I really have to, but I'm just so miserable and useless. And any more than that without sleeping enough, I'm just really feel like I'm going to die. I tried my best to avoid 24-hour shifts when I was working as a paramedic, but occasionally I would forget how terrible they made me feel and work one, and I honestly thought I was going to expire in the morning when I finally got off of those shifts. Oh, it was the worst feeling. I hated it so much. My hat's off to anybody out there who works 24 or 48 or 72-hour shifts. I have no idea how you do that. Every time I did that, I was always like, how in the world do people do that? Like, what would I do if I had to do this again in 2 days? Like, I absolutely could not do it. Data suggests that insomnia affects about a third of adults worldwide, with about 6 to 10% of those meeting criteria for chronic insomnia disorder, more prevalent in women and older adults. And usually these symptoms persist for years. It's not usually a transient thing. From a pathophys point of view, insomnia is characterized by a state of hyperarousal, and that can include several domains, including physiological, cortical, behavioral, and cognitive. So this is a problem that affects us in a lot of different ways and for a lot of different reasons. There can be environmental factors to this, genetic factors, and psychosocial factors. And then throw on top of that, if the underlying hyperarousal disrupts our normal sleep-wake regulation, we often contribute to that ourselves with maladaptive behaviors or thoughts about the whole situation. So it's very easy to come up with common scenarios where you might see this, right? One thing that I think plagues all of us right now is screen time, right? Using screens, shining bright lights into our eyes while we're lying in bed or while we're in our rooms watching television, using a computer, whatever. That's one of the biggest pieces of advice as far as sleep hygiene is avoid screens in the hours before bed because you're just piping bright light into your eyes and stimulating your brain. And you can see how there's a very conscious aspect of that, right? It's kind of nice to lay in bed and scroll on your phone at the end of the day when you're just winding down. In my case, that's usually about the only time I have to do that, but it's not good for sleep. Another big thing that I see and that I do is consuming substances that keep us awake, caffeine being the big one. Man, I love to drink coffee and soda, and a lot of times I don't pay a whole lot of attention to what time of day I'm drinking those things, but I know if I drink something with a lot of caffeine in the afternoon or evening, it's going to keep me awake. And then you get into this cycle, right, where you stay awake too long, so you don't sleep enough, so you're tired the next day, so you need more caffeine to keep yourself awake. It becomes a vicious cycle there. We know that persistent insomnia is linked to downstream problems, including functional impairment. I think we've all probably experienced that to some degree, but also increased risks for major depression, hypertension, and not doing well at work, or not even being able to work. So this is not really a simple problem. This is going to be a short episode. I don't think there's really a whole lot to say about this and how we manage it in primary care. But it's not a simple problem, right? It's a complex problem with several different contributing factors that can lead to major adverse effects or outcomes down the road. It's an important thing and a common thing that a lot of people complain of. So obviously we're not sending everybody that says they can't sleep well to a sleep specialist. So this is something that we need to be capable of managing in primary care. First line treatment for insomnia actually is cognitive behavioral therapy. Specifically, they call it CBTI, cognitive behavioral therapy for insomnia. So really the first thing we should be suggesting to our patients who complain of insomnia is that they go see a therapist who practices CBTI. I don't know about you and your patients, but this is a heavy lift for me and my patients. I spend a lot of my day telling people to go to therapy, to go to counseling for various reasons, because honestly, I think everybody ought to go to counseling. I think that ought to be just as common and recommended as coming in to get your freaking blood pressure and cholesterol checked. I think we should all be getting our brains tuned up along with our bodies. But there is still, I think, some stigma associated with that. Obviously, there are issues of access to care, blah, blah, blah. So a lot of times that's a lot easier said than done thing. At least that's been my experience. There is an app that you can recommend. I think I probably mentioned this before on the podcast. It's a free app developed by the VA called CBTI Coach. I'll put a link to the VA website where you can download that in the show notes. I've been recommending that a lot lately. So far, no one has come back and told me that they have tried it. But what I know about it is that it's supposed to be a pretty good evidence-based kind of approach to insomnia that is somewhat similar to the cognitive behavioral therapy you might get from a real live therapist. cognitive behavioral therapy for insomnia in general, as you would expect, has been found to be safer than medications for insomnia, but also more durable, or its effect is more durable than medications over time. This kind of therapy targets a person's sleep habits, their sleep-wake schedules, reducing arousal that would affect the circadian rhythms, and reframing any unhelpful beliefs that a person might have about sleep. This tends to give pretty quick results that can be sustained over time. We see benefit for both helping people fall asleep and helping people stay asleep. So there's nothing to lose and a lot to gain there from CBTI, so make sure you're recommending that to your patients complaining of insomnia. If you want to just give people some general tips about good sleep hygiene, you can tell people to keep a regular sleep schedule. It's helpful to go to bed and wake up at the same time every day, even on the weekends. Of course, exercise is always a good recommendation for just about everything, but you shouldn't do any heavy exercise within 3 hours of bedtime. Getting some sunlight exposure during the day will help with the whole circadian rhythm thing. Having a comfortable environment. You want a place to sleep that is dark, quiet, and at a comfortable temperature. The other recommendation on environment is only using your bed for sleep and sex. You should not read, should not watch TV, should not use your phone, should not do anything else in bed. You don't want to eat a heavy meal or drink a lot of fluids before you go to bed within about 3 hours of going to sleep. Of course, stimulants, we already mentioned caffeine, but also alcohol and nicotine are good ones to avoid. They recommend avoiding caffeine for at least 4 hours before bedtime. Not a good idea to watch the clock. If you wake up during the night, it's not a good idea to check the time. That's funny. My mother just told me today that she does not keep a clock in her bedroom because if she ever knows what time it is when she wakes up during the night, she can't go back to sleep. How about that? If insomnia is something you struggle with, you can definitely try to limit the number of naps you take during the day. If you do have to take a nap, try to keep it less than 30 minutes and only do so in the afternoon, because obviously sleeping during the day is going to throw off your sleep schedule for nighttime. But that said, I don't like to tell patients that it's bad to take a nap, especially the elderly patients who don't have anything else to do. It seems to freak family members out sometimes when elderly patients sleep a lot. And as long as there's no physical abnormality that's causing that, like as long as it's not secondary to some underlying problem, I'm usually like, you know what, take a nap. When I'm 80 years old, I don't want somebody harassing me about staying awake to take a nap if you're tired. I feel like that's good common sense advice. Good idea to power down all electronic devices and keep the bedroom free of light emitting sources. That's a big challenge if you work night shift. When I did nights, I had these high dollar blackout shades that were like kind of like folded up aluminum foil that came down over the windows. And I had blackout curtains on top of those with the curtains actually Velcroed to the wall. And I had some kind of thing wedged into the top, like between the curtain rod and the wall. I mean, it was pitch black dark in my bedroom. If you do have trouble sleeping, it's a good idea to get up. If you're awake for around 20 minutes, get up, go to another room, try to do something relaxing in dim light until you feel sleepy again. Reading might be a good thing to recommend as long as you're not doing it with very bright light. And then relaxation techniques can be helpful to recommend. Breathing exercises, meditations, journaling, anything like that. So how about pharmacological therapy? What do we have to offer from a medication point of view? Ideally, you want to save using drug therapy for cases where someone has already tried the cognitive behavioral therapy approach and it's not been successful, or for whatever reason they can't do that. In most cases, I would say the situation is going to be the patient is not going to do that, so they just want a medication. And of course, ideally, we want to use medications that are going to be for short-term use. That said, a lot of people are going to take medicine every night to go to sleep for their entire lives, and good luck getting them to get off of it. But if you're starting this kind of thing for the first time, not a bad idea to start with the idea that, hey, we don't want you to be on this forever. Ideally, we just use this for the short term or only use it occasionally when you need it. I definitely have patients that really only take sleep medicine when they need it and not every single night, but we have plenty of the other kind too. So things that are FDA approved for treatment of insomnia, I think a lot of us think about using trazodone. I always refer to trazodone as an SSRI, but it's actually an SARI. That's serotonin antagonist and reuptake inhibitor. We have a ton of patients on that. That is an off-label use, and the actual data on that really is not very good at all. So I don't know if it's a placebo effect or I don't really know how to explain it. Doxepin is a tricyclic antidepressant that is actually approved for insomnia and has better data and whatnot. Then we have a melatonin receptor agonist, generic name Ramelteon, brand name Rosarem. So the idea is for it to behave like melatonin, which is what our brain uses to regulate the sleep cycle naturally. I will admit that I'd never heard of this. There's an NIH article from back in 2007 about it being a novel hypnotic. So it's been around for a while. I'll put a link to that little article in the show notes if you're interested. We have dual orexin receptor antagonists. These are definitely new ones that have come out more recently. You got Suvorexant, brand name Belsomra, Doridorexant. Oh, that one's fun to say. Doridorexant. Brand name Qvivic, and Lamborexant, brand name Dayvigo. These work by inhibiting neuropeptides that promote wakefulness. Those are orexin A and B. The receptors that the medication blocks are OX1R and OX2R. Our experience with these has not been particularly positive. We have used a pretty good bit of the Dayvigo and Qvivic and haven't really seen a ton of success, I would say. Although a lot of times when we are using it is for people who have already been on Z drugs before, and I think of those Z drugs as like, Dr. James always compares medicines to guns. He talks about BB guns and 22s and bazookas, so I think of Z drugs as being the bazooka. So if you're already used to the bazooka, I don't know if dropping down to the BB gun is going to be so helpful, but that has been my experience with those particular medications. When we're talking about benzodiazepines and Z drugs, obviously these are potentially more problematic, more addictive, more adverse effects. Try to stay away from these if I can. Benzodiazepines act as GABA A receptor agonists. They are effective for both helping people go to sleep and helping people stay asleep, but obviously a lot of risks there. Z drugs are similar medications. They act at that benzodiazepine receptor site, but they're different chemically. They do have a more favorable safety profile than benzodiazepines, so they're actually preferred over the benzodiazepines, but still problematic. I guess these are called Z drugs because they all have Z in their name. That would be the Occam's razor answer to that. So here we have Zolpidem, brand name Ambien, Zaleplon, brand name Sonata, and Ezopiclone, brand name Lunesta. So these are classified officially as non-benzodiazepine hypnotics. I think the most well-known adverse effect of these, particularly the Ambien, is that people sometimes get up and do crazy things in their sleep, including driving and eating and all kinds of scary things. I do have one patient who absolutely cannot sleep without Zolpidem, Ambien, and they tell me that they keep their supply of the medication at work and take a single dose home with them only every evening, because otherwise they will get up in the middle of the night and take more of the medication without realizing it. That doesn't exactly make me comfortable, but it seems to work, so okay. In my experience, that is pretty rare. Most people do fine with these. It is a little scary giving them to elderly folks, and that's probably one of the bigger issues that I run into day to day when we're talking about insomnia management. You're always struggling with whether or not to give elderly people medications that you know you probably really shouldn't give them if you had a choice about it. You know, there's the whole Beers criteria thing, which when you read about that, when you're in school, Beers criteria just sounds fantastic. Like, hey, here's a roadmap. Like when I get in practice, I'm going to take everybody over 65 off of these medications, no questions asked. Well, good freaking luck. The Beers list is extensive. There are a lot of common medications on that list and a lot of medications that people need. And it's so flippin' hard to figure out what the right answer is, you know? You have 80-year-old person who can only sleep if they take their Ambien every night. You have the devil on one shoulder telling you this is what the patient needs, this is what the patient wants. They have to sleep. It's important. They don't want to give it up. And then you have the angel on your other shoulder going, this is making them more at risk for falls and cognitive impairment and hip fractures and blah, blah, blah. And they're going to die because they're on this Ambien. So, what do you do? It's such an aggravating situation. Good luck. That's all I know to say about that. Good luck. I think the formal medical way to say that is patient-centered decision-making, meaning you have to negotiate with each individual person and do what you think is right in that individual situation. Nothing's easy, right? Everything's gray. And then finally, we have the benzodiazepines. These are triazolam, temazepam, esdazolam, flurazepam, and quazepam. Temazepam is typically the one that we use or see in practice. You also will definitely see people using clonazepam, lorazepam, and alprazolam as sleep aids, even though they are intended more for anxiety. Kind of the same thing in my mind, same thought process and same decision-making process as with the Z drugs. You'd rather not use them. You'd rather stay away from them if you can. Somebody's doing okay on them and they need them. Well, okay, patient-centered decision-making. There you go. There are definitely other things that get used as sleep aids that we don't have a lot of compelling data for. Of course, there are the over-the-counter sleep aids, which typically are going to be some combination of melatonin and or an antihistamine. It makes sense that melatonin might be helpful because that's the chemical that our brain uses for this anyway. Actual data says that it's not very effective. Anecdotally, it seems like it's hit or miss. Some people swear by it. Some people say it doesn't do anything. I don't feel bad about recommending that. And to me, I'd rather recommend the over-the-counter stuff first if somebody is going to try a sleep aid, and then we can move on to the prescription stuff later if those don't work. That's just me. That's my personal opinion. Antihistamines, a lot of the PM products, Tylenol PM, Advil PM, if you look at the labels, the PM part usually is just diphenhydramine, Benadryl. You will see doxylamine and hydroxyzine used for this also. If patients tell me they're taking those, the ones that have ibuprofen or acetaminophen in them, I will often say you can just take Benadryl instead of getting the ibuprofen or the acetaminophen or whatever it's mixed with that you may not need. Patients have definitely told me that Benadryl by itself doesn't do anything for them, but Advil PM works or Tylenol PM works. So, whatever. Okay. But again, we don't have a great amount of data that says that those are effective and safe. Antipsychotics, we definitely see those used as sleep aids. The most common one I see is quetiapine, brand name Seroquel. Also, olanzapine gets used like this, brand name Zyprexa. Same thing, not a great amount of data to show that they're all that efficacious for insomnia and a lot of risks of short and long-term use. You see some of the other tricyclic antidepressants used like this, mirtazapine or even sometimes amitriptyline. Again, insufficient evidence for efficacy of those. Sometimes you'll see the gabapentinoid medications, gabapentin or pregabalin, brand names Neurontin and Lyrica, respectively. Limited data for efficacy, short-term and long-term risks. In practice, in real life, of course, a lot of people take gabapentinoids. I've just seen some headlines just in the last week or two about gabapentin prescriptions soaring. I haven't read the articles, actually. I just read the headlines, so I don't have anything more in-depth than that. But it kind of makes sense. We're all trying to get away from opiates, but guess what? People still hurt. And I reach for gabapentin a lot for folks with any kind of neuropathic pain, whether that's from actual peripheral neuropathy or cervical or lumbar radiculopathy, postherpetic neuralgia or pain associated with active shingles. You can also use it for hot flashes, for chronic cough. So we end up using a lot of gabapentin, and a lot of people tell me it helps them sleep. I don't know that I would write that just for insomnia. That would definitely be an off-label use, but if somebody's taking gabapentin at night for their neuropathic pain and it helps them sleep, great. I'm not going to take that away. So I think that's about all there is to say about insomnia. So my little personal algorithm that I kind of go by in practice is I will tell people to try the CBTI app or go to a therapist to do this. I'm pretty sure nobody actually does that. After that, I'll recommend melatonin or Benadryl. After that, we'll move on to prescription sleep aids. I try to do doxepin or trazodone as my first line medications. After that, a lot of times I will actually try quetiapine, Seroquel. To me, I would rather do that than something that's controlled. That's what we do in our practice. After that, if someone's never been on a Z drug before, I think that would be a great patient to try one of the DORA medications. That's dual orexin receptor antagonists. My opinion is that those have a lot better chance of working if somebody has never been on a Z drug before. And then if all that stuff fails, then maybe we move on to a Z drug, and last resort would be a benzodiazepine. And as far as the other kind of miscellaneous ones that don't have a lot of evidence, that are not indicated for insomnia, there may be situations where something like that pops up and it makes sense to use it. If you're going to use a tricyclic for something like chronic pain or depression, and maybe there's an insomnia issue as well, that might be a situation where you go, well, try taking this at night and see if it helps you sleep while we're treating this other problem. And I'm definitely not going to tell somebody to stop using something like trazodone, melatonin, antihistamines that we don't have a lot of evidence for, but it seems to work great for them. Well, hey, keep using it. If it's not a problem for you, it's not a problem for me. I think that's a don't fix it if it ain't broke kind of situation. Another big thing to think about with any kind of sleep disorder is, does the patient have sleep apnea or not? That's not what this podcast is about, but that is a very prevalent medical issue that probably goes underdiagnosed and undertreated. And you can really make a big difference in somebody's life, not just from a sleep perspective, but from a cardiovascular perspective, if you can diagnose and treat sleep apnea. So I'm very quick to offer sleep studies. I found that a lot more people will go for home sleep studies, but you have to remember that a home sleep study really is just pulse oximetry, as far as I can tell. So it's good enough to say, does the patient probably have sleep apnea or not? But if you think somebody has a more complex sleep disorder for some reason, you're going to want to send that patient for an inpatient sleep lab kind of sleep study, or just refer them to a sleep specialist and let that person deal with that, unless you happen to be comfortable dealing with more complex sleep issues for whatever reason. And if you have time, it's not a bad idea to get into this a little bit with the patient and kind of talk more about their sleeping situation. I have one patient. The only reason I remember this is we have this conversation every single time I see this patient. They live in an assisted living facility, and their neighbor has to get up and pee. And Evidently, the bathroom is right on the other side of the wall of where my patient sleeps. And so they hear this toilet flushing all night long, and it keeps them awake. And they've said, I've asked my neighbor to not flush the toilet during the night if they have to get up a million times. Just pee in it and flush it in the morning. So they have tried to address the problem. I think they've complained to staff about it, but I don't know. What can you do? Like, that's somebody's residence, and they're going to do what they're going to do. Maybe if they're awake, they don't care if anybody else is awake. But that's a situation where there's really an environmental issue that I don't know that I could do anything about, or that they could do anything about, short of homicide, which I do not recommend. And speaking of bladder issues, that's another important thing that often comes up during conversations about sleep problems. A lot of people will tell me that they don't sleep well, and then they will go on to say, because I have to get up 15 times every night to urinate. And that's something we can often do something about, whether that's medication to help open the pipe, shrink the prostate in the case of males. Those would be your alpha blocker medications like prazosin or tamsulosin, brand name Flomax, or your 5-alpha reductase inhibitors like finasteride and dutasteride. Then, of course, you have surgical procedures which can address the prostate issue, or use medication to help relax the bladder. That can be done for both males and females, of course. The older anticholinergic medications like oxybutynin and tolterodine, the newer bladder medications which are beta-3 adrenergic receptor agonists. These are mirabegron, brand name Myrbetriq, and vibegron, brand name Gemtesa. So that may be a problem that's sleep adjacent that you could address for the patient and help them with their insomnia in a backwards kind of way. And one last pro tip, make sure that your patients are not taking their diuretics before they go to bed. Every once in a while, I will run into somebody who's taking their HCTZ or chlorthalidone or Lasix in the evening, not really thinking that that might make them pee all night. There are some people who have heart failure that's bad enough that cardiology will tell them to take their diuretics morning and night, but generally that's not most people. So, okay, there you go. There are my thoughts on insomnia. A lot of my reference information for this episode was generated by Open Evidence, this new medical reference program that I'm using. I've said that I would update you guys about how that's going, and I really like it so far. You just get in there and ask a question, and it, bloop, here you go. I think I can share the actual information I'm looking at in this Open Evidence conversation by putting a link to it in the show notes. So I'm going to try to do that. If anybody tries to look at that and it does not work, please let me know. But I'm a fan. I really am a big fan of this Open Evidence thing. This is not an ad. They're not a sponsor. But if you would like to be a sponsor, Open Evidence, hey, get in touch. I'll take your money. Thank you so much for listening. Special thanks to our Patreon supporters. I hope you have a wonderful week. Sleep well, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.